All right. Welcome back to another PCBH Corner. I'm really excited to have Jodi Polaha here today. And Jodi, we've been we've been talking about doing a PCBH Corner for a while now. So I'm actually glad that we get to have this here. And my mind predicts that most people probably know who Jodi is. And at the same time, I think it's probably always great to do introductions. Jodi, do you want to give an introduction of who you are, where you're currently located at, and anything unique, interesting that you think would be cool to
Sure,
share?
I'd be happy to. I'm Jodi Polaha, and I'm at East Tennessee State University in the College of Medicine, and that's kind of where my appointment is. I have a pretty unique role here right now. I'm running a director of the Institute for Integrated Behavioral Health, which is kind of a little startup company within the College of Medicine. And I run it very much like you would see, any entrepreneur trying to diversify our funding base and kind of going around the town, sort of shopping it around every corner I can. That's part of what I do in this role. And the Institute has a few major objectives. And one is just within our own enterprise, we have many clinics served by ETSU faculty and staff. The enterprise is known as ETSU Health. Some are nurse-led clinics, some are physician-led clinics, et cetera, et cetera. So one goal is to improve patient care through integrated care, and just looking at patient satisfaction and outcomes. Certainly to improve physician and provider generally well-being by serving through integrated care. And that's one big objective. Of course, resident and other interprofessional learner training is secondary to that and well coordinated with that. We also have a HRSA behavioral health education and workforce grant. So we've got about 15 to 20 trainees each year across a bunch of behavioral health disciplines that we're working through our clinics to get experience in integrated care. We have a strong evaluation and research arm. We have faculty on the traditional side of campus that are in the Department of Psychology that are affiliated with us. And one in particular, Dr. Aubrey Duicki, who has really developed her research program around our work. And then lastly, our role is, and we can talk about advocacy later, I hope we get to, but to really advocate for integrated care regionally. To serve as a capacity building agent to kind of inspire we don't have much integrated care around here. So we're kind of to move that needle a little regionally. So that's what I'm thinking about all day long.
I tell you what.
And then of course I've been involved in CFHA for a long time, and I'm currently the editor of Family Systems.
Like there's so many moments that could be like a no big deal moment of doing all these different things, and the one thing, and totally going off script right now, because as we were talking about it, made me think, I always forget about this. I want to talk to you more about it. It doesn't have to be today. This is probably more of a side conversation with CFHA. You, and I forget the other person that they really highlighted, probably have the most famous article ever written about, PCBH in the Atlantic, correct?
Oh, yeah.
And how many years ago was that? That was what, like?
It was 2015.
Yeah.
2016. I can't remember. Somewhere around there.
So if people are watching this and they have not read that article, it is, and I love how they describe you and just different stuff. Like it's a legit Atlantic article, and I don't know if it was just about integrated care, right? It wasn't necessarily about PCB. Yeah.
It's a wonderful article about integrated care in that, as only the Atlantic writers can do. They're so talented. They tell it as a story, and it's Dr. Tom Bishop and I, and these two people and their lives and how they do this work. And it could have been 2017. Now that I'm thinking about it, I think it was 2017. It was after the election. And that reporter spent like 3 days with us, and she did a fantastic job. What's funny about that was that when she called me, she emailed me. She said, I'm a reporter for the Atlantic, and we're thinking about doing a story on telehealth. And I said, well, like, why don't you give me a call? Let's chat about this. And I thought it would be like, we have like, the Greenville Times Atlantic newsletter or something. Like, I did not believe that this was the Atlantic, right? Like, there's no way, right? So I spent like an hour on the phone with this woman, and I was kind of kicking myself later, like, why did I just give this stupid newsletter all of this time? And I convinced her not to do a telehealth story. I told her, you really do a story on integrated care. This is where it's at. And she said, I'm going to pitch that to my editor. And she did. She got back to me a couple of days later and said, my editor loves this idea. We're going to run with it. And then I Google her and I'm like, oh, it is the Atlantic. The Atlantic is doing this story.
I remember even when I think I first, because I think you sent an email or something about it, and I was like, the Atlantic.
I know.
Like the
Yeah.
Atlantic,
Yeah.
it was incredible. And I would love the one story, again, I'm going off on tangent, I'll bring us back in. What was the one story that you quipped with the resident? I think they asked for a handoff. It was like, oh, you just checking Facebook or something like that.
Yeah. Yeah. Well, it is, and it doesn't name PCBH in it, but it does actually allude to a lot of elements of PCBH.
No doubt.
And apparently, this one resident they wrote it all down. She recorded everything I said for 3 days. She was doing a handoff, and she said, do you have a minute to talk about this patient? And then I said, do you mind to make a quick introduction? And then you can go back to, cruising Facebook or whatever it is people do all day. And that got in the article.
Oh, I remember reading it. I was cracking up. Cracking up.
Yeah, they got it all. She nailed my personality and just through some of the quotes she used and stuff.
Which, as you said, I mean, the Atlantic just being a town, that's how I felt too. The article, just you could feel that presence, and as you said, that story. And I think it's something, as we move on to some of these questions, I said this about Deepu, and I should say it about everybody, but I've had this moment with Deepu, and I definitely have this moment with you, Jodi, and really encouraging people that do watch this, that, if you see Jodi, at CFHA or at a conference and stuff, like, definitely go up and talk to her, because I just find your humor is just off the charts, and it's so easy to connect with you, but then just so willing to have conversations, which I'm sure, and again, with the article, what made the article what it was sure. That ability of connecting and that ability of telling those stories. So sorry if you don't want people coming up to you at conferences and stuff, we're going to put it out there for people to do that. Yeah.
No, it's funny you should bring that up, if you don't mind me responding to that.
Please.
For a moment. Of course, I came to CFHA as a new member in around 2005 or 6, and kind of appreciated what was going on within the organization, and felt like it spoke to me and what I was about. But what really hooked me in over the next 5, 6, 7 years was the way in which members practiced what I will call radical hospitality. A real orientation and constant sort of orientation to, how do I greet people? How do I bring people in? How do I welcome people? And people that I barely knew that I knew were leaders of the organization, people I'd only shook hands with once, that were on the podium, were chatting it up with me in the elevator. And, I was just kind of a nobody, but it was just so incredibly, it was such a value that was being played out.
No doubt.
That was so different from any other conference I'd ever been to. And then it was Jennifer Hodgson, who really took time. I mean, lots of people took time, but I remember her especially took the time to, explain the potential for me to get involved, and gave me some directions on how to get involved, and mentored me through some early stages of involvement with the organization. And that's that kind of selfless giving and welcoming is something that you never forget, and you want to pay back. And I've been thinking about this a lot lately, because we haven't been around each other years, right? Or however, it feels like a century, but it's been a long
Sure.
time. And I worry about, when we are back together in person, we've got a bunch of new people, people don't know, it would be easy to lose that culture is where I'm going. It would be easier for that to get dropped because even the people who are seasoned and have been around, myself included, may feel a little off kilter, right? Like, oh, am I supposed to know that person? Like, have they been like the president for a few years and I didn't realize it because it's all been online, and I'm exaggerating, but you know what I'm saying? Like
For sure.
you just feel a little less, and we're going through this as a nation, like in all social situations. But all I'm saying is I hope when we are together again, we can bring that sort of level of openness and welcoming to our group.
Oh, that's awesome. No, and it gets me hyped for CFHA, and I couldn't agree more with what you said about just I don't know, CFHA, the feel, the spirit of the conference is just different. I mean, the content, I was talking to Stacy about this, right? The content is always great. It's these side conversations.
That's right.
It just is incredible. So it's a good segue, I feel like, because talking a little bit about your beginnings with CFHA, I'm always interested in hearing people's, I'm trying to think, Jodi, if I've ever heard your story. I don't think I have. So I'm really pumped about this right now, about what got you in to, integrated care, what got you into PCBH. I mean, we were just talking about before that, coming from the, school at the great city of Pittsburgh and all these different things. I mean, what was your journey in? If there was, because I love talking with Kirk and Patty and Jeff about this, about any accidents that happened that was like, man, if this doesn't happen, like I'm not at this place right now. I'm not connected right now. So yeah, where's your mind go? What's the journey? What's the story to where you're got to right now?
I love my origin story. I'm struggling right now. So I'm like, how much of this do I tell? This could be the whole PCBH meeting. Well, I graduated with my PhD from Auburn in clinical psychology in 1998. And I had been in Alabama for many years and I fell in love with rural work. I had already been very influenced by a scientist practitioner model of sort of way of being. I very much saw myself as oriented to behavioral interventions, evidence-based interventions. My graduate program had another degree program in applied behavior analysis, and I took many of those courses. I had many colleagues that were ABA experimental colleagues. I found that to be very interesting. I was pediatric oriented, so a lot of the behavioral interventions for kids and whatever. And anyway, wanted to do rural work, wanted to strengthen my ABA skills, and I went to Omaha because the University of Nebraska Medical Center had a very strong program in all of those things, and did an internship year and a postdoc year there. And during those years, I got to travel the state of Nebraska, which is actually a very beautiful state. Most people don't know how beautiful it is because they just drive through on the interstate, which is the Platte River Valley. You don't see any of the cool stuff. But we travel all around the state quarterly and even more often, sometimes by plane. With an interprofessional team, we saw really complicated pediatric cases all around the state. And the physicians and whoever did their part, and then, inevitably it would be like, okay, now we know it's this genetic syndrome, but like, what do we do about the fact that he keeps sucking his thumb? Or how do we solve the problem of he won't go to the potty? Or how do we make him participate in these PT exercises he doesn't want to do? And then that's where I would come in. It wasn't long before I realized there's no help out here. I mean, one session with me is fine, but it'd be great for them to have a few follow-up visits with somebody, and there's nobody out here. And then I got to know pediatricians out in upstate Nebraska. Long story short, I ended up practicing in a rural pediatric practice about 2 hours, two hours and 15 minutes from Omaha. And I would drive out there on a Tuesday morning, see patients all day, spend the night in this comfort inn, see patients the next day, and then drive home. I did that for 4 years.
And that was
when I
after
left,
internship and fellowship. This is like first
yes,
job.
I took a
Wow.
permanent position. That's right. Thank you for connecting the dots. And started seeing patients in this pediatric practice. And the story I tell all the time is that when I started there, they knew I was coming. They knew I was going to see, 15 patients over 2 days. And when I walked in the door on the first day, they had an 85 patient waiting list. And I'm sure that you can already see where this is going, because I took the first 15 and I planned to do, CBT, whatever the thing, because this is 1999 or whatever, 1998. And 1998. And, we looked at the data 4 years later. My average number of visits per patient was 5.5, which is incredible when you think about that. Includes all the people that came once and never came back.
Right.
That's a high batting average for like a traditional mental health service.
Dang right.
So obviously, if I'm seeing 15 people for 5.5 visits, by the time I get openings for some new folks, the list is back up to 85, right? Like this thing never, in 4 years of being out there, I never got the list down. The good news is it's still out there. It's still one of our postdocs. I've trained postdocs, I trained people, and eventually they hired someone, and that clinic's still there today. And while I was out there, I did train many postdocs in many sites around the state, and they're all still in existence. There's probably, I'm just guessing, 14 or 15 outstate integrated sites in Nebraska in pediatrics and family medicine that are really thriving and doing a lot of good work around workforce development and, of course, getting behavioral health services out, and of course, better primary care. But that work and that waiting list was all it took for me to see that method of care, that model of care was, I felt like I was causing more problems than I was solving.
Interesting.
I would come in and they would be losing their minds. Like, do you have an opening? We've got this kid, and I'd be like, sorry, no, I sure don't. And then there'd be fist fights if I did, right? No, my kid gets in. No, your kid gets in. No, his kid gets in. I was there first. You were there first. My kid's worse. My kid's worse. And, I had this like whole vision of myself like superhero coming into this rural community. I'm going to solve this mental health problem, get to see all these kids. And all I was doing was causing, stress, because I could never get these kids into these 50-minute slots. And 2000, I'd been out there for a couple of years. Herc Strassel came, did a talk for Nebraska Psych Association. I drove him from the airport to the talk and introduced him. I had a full-on panic attack while introducing him. Completely couldn't.
Like legit panic.
Yeah. People don't know this about me, but I have a history of public speaking panic attacks. And it usually happens when I'm introducing myself or, in the early moments.
No shit.
I had a full-on panic attack, tunnel vision, couldn't breathe, couldn't talk. I was like 10 words in. And I just did a bunch of acty things, right? Because that's the only thing that gets me out of it, is just to say I'm like totally falling apart, saying I'm sorry to the audience. This is just what happens to me sometimes.
Yeah.
And it was so cool because, of course, I was mortified, as I always am when I have a panic attack in front of 100 people. And Kirk got up and was like, that was like the most perfect act moment I've ever, witnessed. It was the greatest response. It's funny, as soon as I acknowledge it and say, this is what's going on with me, what's going on with you? And then I'm fine. It dissipates and I just go forward.
Stephen Hayes, I'm sure you know this about Stephen Hayes, right? Yeah, exact same kind of story. It's interesting.
Yeah. I've dealt with it my whole life. And, it's been better in the last, I'll say 6-8 years, but for a period of time there. Kirk came, spoke a lot about PCBH and this model. And I was so intrigued. I was like, yes, that's what we need to do differently because what we're doing isn't working. Because I was out there doing co-located stuff and really I've gotten through it. Anyway, I care. And that's the origin story. That's really what kicked it all off. And I could talk about it a whole lot more, but that's how I got started.
Jodi, that is great. Now, I will say, Jodi, you are frozen on my screen right now. I don't know.
I hope I have a big smile on my face.
There, you're back. You're back. You know, I mean, so many different things that I wrote down, and it almost ties into what you were saying a little bit about your current work right now, which is this entrepreneurial kind of approach. And it seems like even in that initial pediatric rural clinic of, you know, man, we could probably spend a whole 20 to 30 minutes about what that experience was like. And because it sounds like what you were the first psychologist, I'm assuming, that was there, right? Yeah.
Yes.
And how to build that up. And the thing that I love that you said that I wish, I don't know why my mind says it sounds bad, but that it seems like you were really critiquing what you were doing in that setting to the point where, as you said, like, I don't know how much I'm like helping this right now, you know, and I think that's a really tough thing just for people doing integrated care, and particularly at new sites and whatnot, of really critiquing. And what I do, is this actually providing a benefit, not only to the patients, but as you said, even the providers that are just like getting upset now. Yeah.
Right. Yeah, I think that I have so many thoughts. I think that has been the great challenge of this work, which, you know, it seems crazy that 23 years later, I'd still be calling it innovative work. Come on, what is going on here? But it's true.
No
and
doubt.
I think that's where I thrive, you know, is in, unfortunately, I seem to be drawn to these roles where there's a lot of kind of almost, I don't want to say conflict like in a negative way, but this constant like rough edge, right? Where it's not getting paid for, people don't understand it, you know, your neighbors don't like it, whatever. And you're having to think marketing, and you're having to think problem solving, and you're having to do all, I kind of like that, but it does require an openness to, you know, your own, certainly your own biases, but, and then kind of letting go of that and really being open to what's happening. I'll give you a great, can I give you a great recent example?
Yes.
I had a chairman of our department who was extremely critical of PCBH. This is just a few years ago, and I think I even reached out to you because I was really uncertain about how to handle it. And the criticism was, you know, we had been running a PCBH service in one of our clinics, family medicine clinics, with a couple of students for about 4 years. We tried to fill it with a psychologist, couldn't hire you, but tried to hire you. Anyway, obviously that didn't work out. Couldn't hire a psychologist, and we're running these students out there, and they're taking these handoffs, and they're doing the model the best way that a couple of students can do. Graduate students and psychology, they're great. And the criticism was that if residents are just handing off all these behavioral health problems, they're not learning. And, you know, when you love PCBH and you feel that it really potentiates your skill set as a psychologist, and you feel like you've had 20 years of really good feedback on how it works and what it's for and how it does, you know, there's a defensive response to that. And you're like, well, sure, they're learning, and here's how, and but also, like, what are you wanting them to learn exactly? Like, we spent 6 years in grad school learning all this. I mean, you can't teach that like on the fly or that, like, it's not happening. This is what we do. The whole idea is you're supposed to want us there, right? And well, but you know, they're going to go to practice with no behavioral health service, and then what are they? They're not going to do anything themselves. Well, they've got to go there and get the health service started. So it's a defensive response, and really, I think what innovation requires of us is an openness to that, an ability to reflect on that and think about that. And not long, I don't know, it was a good year or so after I'd been kind of duking it out. and the immediate response is rebuttal, right? Rebuttal and rephrasing and re-arguing and taking a different tact and explaining it again. And it turns out that there's this whole strategy within resident training around micro precepting or micro teaching. And we were like, what's that? Well, it's brief teaching interactions around in the moment, like an in vivo, like patient care teaching interaction. And we ended up coming up with a micro teaching program that we now teach all of our externs and staff and clinicians and faculty. And we kind of support micro teaching in a number of ways and keep data on micro teaching and talk about micro teaching, try to raise the visibility of micro teaching. It's very consistent with adult learning. People learn better when there's a real case in front of them and they're learning about the problem in the moment, as opposed to in some room, right, with a bunch of slides, right? And I think that innovation, I don't know that it's huge innovation, but labeling it, coming up with the curricula, taking data on it, that's all new for us. And I think we wouldn't have done that if somebody had to push back a little bit on that piece.
Let me ask you this, because I think this is a really big topic that generalizes to a lot of different things, but it definitely within the realm of PCBH that is constantly there. And obviously we're both behaviorists, and not wanting to just chalk it up. It's like, oh, someone has the personality for it, someone doesn't have the personality for it. More like, what are the behaviors that allow this to do? So, where does your mind go when you think about what behaviors would you encourage people to do to have that openness, that to welcome that rumbling, to welcome those conversations that, as you said, I'm sure hit to the core of us a lot of times, whether it's a provider that says something or it's like, oh, that's no, we don't need you for that, we don't want that, which I'm sure BHCs that are watching this all day every day, especially in new systems they're getting. I mean, what would be the behaviors that you would encourage people to do that would allow that leaning in rather than leaning out kind of stance?
I think attention to your internal response. All those internal cues that very provocative, and especially the negative ones, right? And then kind of being able to reframe those or experience them a little different, experiencing them as opportunities instead of something you need to run away from, right? I can remember 10 years ago realizing that, and it took me a long time to come to this, but the things that scared me the most were the things I needed to go toward, right? Like these are the challenges, these are the leading edges, these are the things that, and it's sort of like that, it's like the things that irritate you the most, the comments that really chafe, right? The criticisms that you feel like are unfair. Those are all opportunities to think about innovation.
Oh, that gets me hyped. That gets me hyped in so many.
Yeah.
And I think this is something, obviously we work with trainees, and this idea of whether it be leaning in or just trusting the process, it's like this is part of this experience, and particularly for BHCs, that this willingness to be uncomfortable. And what do we always say, right? If particularly if it's a PCP giving feedback that's negative, I was like, what's worse than that? Them not giving feedback because they're not engaged enough to even care. That's right. And as you said, that reframe, that's seen it as an opportunity. That is cool. That is cool. So let me ask you this. I know one of the topics that obviously is near and dear to your heart that you talked about is this evaluation, tracking data, getting things out there. And then obviously your role as the editor of Family Systems and Health right now, there's a big value and a large component of that. And this is probably going to be a broad open-ended question. So honestly, I think wherever your mind goes, even with that prompt, I think go with. And then also, are there things or is there anything that you would encourage on the boots or on the boots. Jeez, oh man, boots on the ground
Put the
clinicians.
boots on.
Put the boots on. Boots on the ground clinicians. One about why this is important to be tracking data and promoting, and then also suggestions for these individuals. And I know you've been very useful for Bridget and I, because we're not researchers in a lot of ways, about how to get data out there and who to partner with. Like, again, that's broad, open-ended. Where does your mind go with any of those things regarding the research aim of this, and then also the tracking, evaluating yourself?
Sure. Well, I think we've made the case in a number of articles now, and I think one of them you could find is a Jodi Polaha editorial that we wrote for a special issue we did on like practice-based data and how to collect it and how to do it in 2018 or something, So for a long time, I think we've held, and those articles kind of lay out like with value-based payment and some of these changes in the system, there's more pressure on clinics to take data, keep data, and have a clinical informatics staff, and kind of a lot of demands to constantly like kind of make these iterative changes around what we're tracking and what we're asking and what we're marking, because we've got to meet these metrics to get the carrot, out of this value-based system. And so it's a shift in the direction of empiricism, and it's being driven by payers, right? And that kind of happened around the same time as the quadruple aims, which oriented us to sort of some four key outcomes that people should be thinking about. And so now we've got sort of an orientation to outcomes. We've got a shift toward like data sort of available. And in the meantime, where we are is in this context where a lot of the research that comes out has little applicability to clinic-based settings because it's done by people who aren't in clinic-based settings. And there's this like kind of loss or of transfer of critical information about, what the real world needs in order for this to work or for this to be implemented effectively. That's a great idea, but we can't get it paid for. That's a lovely idea, but nobody wants to talk about that in primary care. It's uncomfortable. Maybe it's a really good evidence-based treatment, but it takes too long and nobody wants to come to that many visits. So we're in this world where this disconnect between science and practice, and now practices are starting to generate some numbers because it's not clean data and it's not research with a capital R, but it's some data there. And what if we could get clinics to kind of start feeding some information the other way, back toward the scientists that are in the applied part of we call it the translational bridge, that are working on these randomized controlled trials and stuff, so that they could better design those trials and make them sort of more articulated to what's actually happening out here and what people are actually talking about. So I think there's a real place for studies that come out of practice and really have always encouraged clinician innovators, people like we were just talking, people who are okay with being uncomfortable with what's not working and the way it makes them feel, sort of saying, what can we do about this? I actually think that quality improvement is a way to combat burnout in primary care, not only among our behavioral health folks, but certainly among physicians and nurses and others who could ideally participate in some brief meetings around a little localized problem, use a database approach to solving it, and then feel like empowered, like, hey, we fixed this dumb thing that was we were stubbing our toe on every day. And now we don't stub our toe anymore. And our patient is getting better care, or, our physicians aren't having to spend as much time or whatever. These little kind of team-based 30,000 foot system change processes are, I think, a way of really driving some resilience in these settings where you really do feel powerless a lot, right? Because there's kind of constantly these changes coming, and sort of burdensome processes and everything else. So here's your chance to impact that.
I love that subtle kind of, as you said, the burnout prevention that this could actually, because I don't know, I've never heard that described that way, right? That this could be a big, that is cool. That
and
is
I've
really,
had that thought for a while, and I've heard other people say it, so I don't think it's just me. But what if you're, so for example, we call them champion teams here. It's a little project I've done where we have 30, 40 of these that we've done over the years, where we say, okay, we want to improve uptake of immunizations. This was pre-COVID, just flu, right? We want to go from 30% to 50% uptake. What can we do? And we had a little team of people that are professional, and we did like 30-minute meetings, and we had some do outs. The big heavy lift do outs were done by clinical informatics and people like me who have time bought out for that type of stuff. No big do outs for the clinical people. And then come back together, action items reported in, here's the rates, here's what we got, blah, 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 here's some ideas. And, we did it over 2 years. We did this intervention. It took 2 years to get it there, but we got up to 55% of our clinic getting flu vaccine. It's a huge difference. It's like the upper end of what you ever hear about primary care, from the lower end to the upper end. And that feels good, right? Like for all the whole practice, but especially for those on the team.
Absolutely. I'm mindful of time right now, and each one of these topics, we could have talked for 20 to 30 minutes. So let me ask you this as we begin to wrap up, and we'll try to, again, hopefully do part 2 of this in the coming months as well. Maybe we'll do it at CFHA and we'll film it there. Let me ask you this, one of the big things that not only, as you described at the beginning about advocacy work that you're doing within the state, you'll probably, I don't know of anybody else in the, CFHA or PCBH community that actually holds a public office some way. So obviously advocacy is a big part of who you are and your values. Would you mind talking a little bit about where that comes from, why, and then also any suggestions for CFHA members or people working in integrated care that are interested in doing advocacy work, and it just seems like too big of a thing to get involved in? Like there's no direction, like no holds that you can actually support yourself with. Where's your mind go there?
Well, of course, advocacy is huge for me. How I got interested in really, this is about civic engagement broadly, is just being in my neighborhood. And I moved into this cute old historic neighborhood, and I had this vision that it was going to be this way, right? Like we were all going to talk on the sidewalk and pass tomatoes over the fence, and our kids would be friends and whatever. But after I had been in that neighborhood for a couple of years, I realized that if that's the neighborhood I wanted to be in, I had to make it be so. That neighborhood doesn't become that. You don't just show up and the narrative plays out exactly how you have it in your head. You actually have to sort of move that yourself. I got involved in some zoning disputes that had implications for that kind of community. I started delivering the newsletter for the neighborhood, started writing the newsletter for the neighborhood. I ended up president of the neighborhood, which it's not a HOA, it's a community neighborhood organizations, like picnics and stuff, and art projects, and getting people together in meaningful ways. And while I was president, we went to bat around this old historic mill property. They were going to raise the mill, and we ended up getting it saved and preserved and built into something beautiful. And it just, not that I personally did that, I was the president at that time, but just to see people come together around something they cared about felt like maybe the most important work there could be. That kind of advocacy and sort of kind of claiming your power around an issue. So anyway, that story goes into me running for office, and I've been a county commissioner for 4 years, and it's too much to tell on this call, but it has been amazing to be on a board of 15, and I'm the only voice for lots of things, but one of the things is healthcare. There's no other healthcare people. It's a lot of bankers and lawyers and business owners in the private sector, and just to have somebody on the commission that can speak to healthcare issues is huge. The other thing is I'm a longtime educator, right? So I can break things down and educate. We get these people come in with this content expertise on a complicated topic like building an athletic field, what it takes to turf and how to do this and that. And if I can understand it well enough, I can explain it to people. And that makes a big difference. A lot of times, a lot of our commissioners don't understand what we're talking about, and somebody just needs to articulate it in a way that everybody gets. And if you've been a teacher for a long time, you can do that. So between the healthcare advocacy and teaching, and it's all stuff that's local to my community, it feels like I play a big role, even though, coming in, if you look at me and you compare me to my colleagues on the board, I look like, you probably don't remember that Sesame Street one when they'd be like, can you guess which kid doesn't fit in, right? Like this is the one over here. And that's me. But all of this to say that, I think for anyone out there that's listening, it's all about picking something you care about. That's how I got into it. What really matters to you, and who are the people that are with you on this, and then who are the decision makers that you can reach out to and interact with and impact. We're doing some advocacy. Our group here, the Integrated Behavioral Health Clinic, is doing some advocacy with our state house representatives around licensure, which is a problem in the state, and also around workforce and creating internships and fellowships, and just the state just needs to fund some of these things, right? Because we have these gaps in the pipeline. And it's I will say this, it's an advantage to be a county commissioner and calling your state house
I bet.
and saying we want to have a conversation about this thing. So if any of you out there have an interest in running for office, there's actually a few people in CFHA who are in elected positions or even are running for elected positions. I mentioned Jennifer Hodgson earlier. She's running for school board right now. That's a big one. I'm sure any of us would be more than happy to talk about that and what it's like. And like I said, we need more people in healthcare in these roles. It really does make a difference.
Hell yeah. Oh man, I am, again, so excited about different things. I'll end with this. The first thing is like the subtle thing that you were talking about your beginnings, and obviously the public speaking and the panic that would come in. I tell you what, if that's not an example of approaching something, because again, being in public office, you're gonna have to speak, you have to be involved in these things, like talk about taking that head on. I mean, what a cool thing. And then I loved what you said. And I don't know if I have the words down exactly, but if that's the neighborhood I want, I need to make it so. And not only about our communities, but is that not a damn good analogy for PCBH and integrated care as well? That is, that gets me hyped. Jodi, thank you so much for today. We'll definitely be ended up doing part 2 to this. I know this is going to be a really beneficial one for a variety of different topics and a variety of different people. And I'm just excited for CFHA to be able to see people in person and to go from there. So my gratitude, Jodi. Thank you for.
Back at you, Dave, if you don't mind me getting the last word.
No, for sure.
I admire you so much. Your energy and enthusiasm and positivity, so infectious. And I think in the journal, in the work I'm doing in the journal, it is increasingly clear to me. And I have a huge vision for dissemination and implementation science and making the journal more accessible and more engaged. But really, what you and Bridget and others are doing around informal dissemination channels and the listserv and this PCBH Corner and all of this stuff is a major player in how it's creating the pathways by which some of this stuff has the opportunity to flow. And I have every day increasing excitement about how you're growing the capacity for implementation and dissemination science to make its way through. So thank you for that.
I appreciate that, Jodi. I appreciate that. So again, I hope people enjoyed the PCBH Corner. Definitely, reach out to Jodi, myself with additional questions. And as I said, when you see Jodi at CFHA, go up and talk to her, without a concern there. So,
I would
all
love
right.
it.
Thank you all.
So long. See you in Idaho.